Well, thank you so much, Rachel, for that kind introduction. It's always a little nerve-wracking to hear your own bio, but I appreciate you. And I see many people in the chat that support this work that I'm about to present today. So thank you to all of our colleagues at the Department of Health and Human Services to help us with this. And I'm glad to have Chloe on the call because there isn't a single presentation that IFS does that she doesn't touch from the MCH lens. And we call it, Chloe-fying everything and making it simpler for all of you to kind of digest. Data can be kind of complex, and so we appreciate her as well. She'll be kind of, if you have questions, monitoring the chat and available to answer questions that way. So today we're going to talk a bit about the South Carolina Birth Outcomes Initiative interactive dashboard. Many of you have used it. Some of you are interested in using it. And the specific context of today's presentation, will be just a brief overview. And I know some of you already know this, but why you might want to use this data instead of other data. But the majority of today will be a walkthrough of the actual dashboard, where I'll show you a little bit, especially on the AIM dashboard, which is a big focus in the state, so that you can better understand how you might use the dashboard for your own bedside clinical practice or to drive quality within your hospital. And I've already talked about how phenomenal Chloe is. Many of you know Dr. Lopez Defidi, who was my mentor for nearly 13 years and leads the division at IFS. The data are put together by Dr. Murthy Kodagiri, and the actual dashboard is put together by Courtney Baskin. We have access to the data on the dashboard because of a long-standing partnership that goes back to 2011. It's hard to believe that, with Chris Finney at RFA and with Annika Moonen at the Hospital Association. And through that partnership, we are able to link multiple sources of data to really have robust data on the dashboard. I already talked a little bit about what we're going to talk about today. Currently on the dashboard, all of the data that is available at your fingertips on the public dashboard or through a hospital access is updated through federal fiscal year 2024. It was updated in May. And so it has the data through September 30th of 2024. We're currently drawing down data that would round out the calendar year. And we've been invited to talk at the annual BOI symposium, where we'll share some 3-year, trends for the last 3 calendar years. So if you're looking here on the left, you see a rather complex flowchart. It is quite amazing what our data analysts at IFS do to link data from all of the birth records submitted from the hospitals to all of the UB hospital records for all payers to the Medicaid recipient records, where we're able to, really ensure that Medicaid was the final payer of the delivery, which I'll talk a little bit more about. So we're doing a 3-way linkage and ultimately dealing with very, very messy data. If you can imagine, even sometimes trying to figure out what was the date of delivery when a mother maybe showed up in a freestanding ED and then was transferred to a hospital and then maybe transferred to another hospital. You could have multiple records and you can have a myriad of claims that kind of represent that birthing individual's experience. And so we're doing a lot to clean that data and really make sure that we have a final experience of the newborn outcomes, those labor and delivery outcomes such as cesarean, and are able to really have a robust reporting on maternal safety as part of the AIM initiative. The dashboard's been available since 2019. It's secure, it's online, it's interactive, and as a hospital user, you're able to have your own access to unrestricted data on the dashboard. We filtered the data by a number of filters and we continue to add them. We just added educational level. Before that, we added access to prenatal care, all of the demographics that you're used to. One of the things that's unique is that we look at rural urban based on zip code. So we do have the zip code level data. As a hospital user, you're able to compare where your rates are compared to your same level of hospital, both within tables and charts. We've also added throughout some improvement tips. So if you do see an outcome for your facility that's higher and you're kind of going, where do we even start? There's downloadable improvement tips that we update at least once a year that have links to other quality resources. And of course, this is kind of the home. The funding for the dashboard comes from the Department of Health and Human Services, which is the home of the Alliance for Innovation, a maternal health program. So all things AIM are funneled through the dashboard on the data side of the house. So not to go into this too much, but if you go to the main dashboard website at boi.ifsreports.com, and Chloe, if you could put that in the chat, that would be appreciated. You'll see a whole bunch of interactive use cases of how to use the dashboard to drive quality at your facility. Some more information about measures. If, I know some of the names here. Some of you are really into the weeds of the data, and some of you just want me to tell you the answer. And so if you're really into the weeds, if you really want to know how everything is defined, we have very, detailed definitions and information about the data sources, and a user guide for how to use the data all at your fingertips. So the reporting that is publicly available is somewhat restricted. We don't want to inadvertently share the experience of, let's say, a mother that delivered in a small county, had a poor outcome, and everybody in Williamsburg County knew exactly that that was Jane Doe, right? And so on the public dashboard, we do roll up some data to a certain level, and we only allow filtering to one filter instead of multiple filters. However, the hospital data reflects your data back to us. So if you are an authorized hospital user, you have full access to unrestricted data. So we're not going to roll it up to 10 or do any of that. And you can use multiple filters. For some of the dashboards, if you filter too much, it's not that useful. So you'll get nothing if you do too many crosstabs. So really, we generally suggest that you only filter to 2. If you are sitting there as a staff member at a hospital wondering, how do I get access to my report? There is an access form that is linked to, if you get a copy of this PowerPoint, it's in there. And you fill this out. You have a qualified authorizer at your hospital sign off that you are an approved user. That goes to the hospital association, who then sends us a message that says yes. So why is it so complicated? It's complicated because there's a state proviso within our state that protects hospital level data. So we need to be extremely careful. So legally, we ensure this triangulation where the hospital has approved access. That is then vetted by the hospital association before we, as the data holders, actually release the data. So that protects you as a hospital user, and it protects us on the other side from a legal perspective. So some strengths of the hospital data that are available to you on the dashboard. First of all, I've already talked about that the Medicaid eligibility is verified through enrollment files. If you were to just look at your hospital records or just look at birth records, it would be that expected payer, and that is much lower. So sometimes, and I'll show you a little bit of that, but it's a difference of sometimes 47% to 60%. We are using self-identified race. And so, when we look at self-identified race versus what the billing staff put, it's pretty close, but there is some variance. And so we really want to, prioritize the race that the patient themselves said they belong to. I've talked about the linkage and the confirmation of measures. Often available data through, let's say, Leapfrog or downloadable from CDC, those kind of sources, is quite outdated. And often these measures are changing as the story is changing. Right now, there's a lot of national conversation about severe maternal morbidity and what conditions should be in that measure and which shouldn't. Some variations between how CMS and AIM the CDC, and then how they define it, right? So we're doing our due diligence at IFS to do that for you. So you're not having to wonder, am I using the most recent Joint Commission measure? We're kind of just updating it along the way. Many of these measures want to really know that you're only running them for mothers at a certain gestation or for first-time moms. And so we're able to qualify that from the birth records. I've talked to you about the types of comparison by hospital and statewide, and that we're really looking at federal standards. We've already talked a little bit about all of the resources that are available to you. For the sake of time, I'll keep going, but these are hyperlinked and you're able to access them. So the use of the dashboard for QI. And We have now put together this handy little PDF that is linked for you, and it's also on the homepage. So if you're trying to justify your use of the dashboard or your access to the dashboard, you can just download that and share it. It's beautiful. The examples came from Chloe, and we had a designer work on that. So first, we would want to monitor trends and target outcomes for quality improvement. So you can see here on the right that this is a hospital that's looking very closely at their cases of severe maternal morbidity. And what they can see here is this differing trend for hemorrhage, where they're starting to kind of go down, they're starting to look like hospitals, versus hypertension, which is kind of shifting in that last quarter. And so in this example, the hypertension rates are rising and exceeding the state benchmark, which is that line there. For comparison, you can see the green is perinatal level, orange is the hospital, and the blue is the state. And it's becoming that priority for intervention. So this is that pause moment if you're in quality, if you're a nurse trainer, to say, okay, we seem to have hemorrhage under wraps, and we're following the bundle and things are getting better. But what might be going on with severe hypertension, and maybe we need to have some grand rounds, maybe we need to do some drills, revisit bundle components, and kind of find out if we're missing some important precursors to this. So this is a, masked example, but it's a real example of a hospital that was improving as we were doing the AIM bundle for hemorrhage and starting to have some slippage for severe hypertension. So here, this is really the comparison across your hospitals. So some of you have access because of where you're situated within, for instance, Prisma Health, where you need to oversee quality across every single Prisma Health facility. And you need to really prioritize your resources in terms of time for training, your resources in terms of enhanced payments to providers. And so as kind of an upper level user, you actually have access to all of your hospitals. And one of the things that we've been really wanting to do that's kind of in the parking lot, and it's kind of a wish list that may happen in the future, is the ability to do a systems level report, which is a little complicated to do that roll up, but you're able to have access to every hospital within your system, granted an authorizer such as a CEO, a CFO, or a quality director says you can have that access. So many of our OB leads like to have that access and have even used it to, for instance, defend that more resources are needed at a hospital you might not think needs as many resources, because in the end, they're actually seeing almost all of the high risk or high acuity patients. So this is just that comparison there to look at the hypertension cases being, 31% at that second hospital with a decrease over time, and just comparing that first hospital is going to need some more resources for that bundle implementation. So, of course, we really want to ensure that populations achieve their full potential. And this is why you can do customizable data filters at many different levels. In this example, we're just showing you that you can filter the data for rural recipients that have Medicaid as their payer. But we currently have 11 filter types and 53 unique data filters across all of the measures. So here, we're looking at different types of outcome data. For those of you that do quality work, we have on the dashboard the PCO6, the PCO7 measure. We no longer do the early elective induction because that measure as a national metric really got a little wonky when ICD-10 came in and shot up as coding became so broad that it was hard to really look at inductions. But we have the PCO2 measure, and I think I misspoke there with the number for the Joint Commission Early Elective Delivery measure, but we have unexpected newborn complication, and we have the primary cesarean measure, and we have all of the codified AIM measures. So a question we often get is about, I won't use the word fairness, but maybe the equity or appropriateness of looking at a hospital's primary cesarean rate without looking at the newborn outcomes, right? So if you know anything about the primary cesarean rate, it's looking at those moms over 37 weeks who are not transverse or breech, who haven't had a prior primary cesarean that would justify, for instance, a second cesarean, and who are not having multiples, right? But that definition is not taking into consideration whether or not, for instance, there's been an unexpected newborn complication, something that was going on with the fetus that would lead to that cesarean. And so the ability to kind of look across, right, to look at prematurity and SMM, for instance. For instance, we know that 50% of those who have a severe event at delivery are also premature or had a low birth weight delivery, right? That these outcomes don't stand alone. And as a user of the data, you might want to be able to go to your hospital and say, well, yes, the rates are higher, but I'm also seeing a higher acuity patient load because you can filter the data, for instance, by diabetes and hypertension. Or I'm also seeing a higher rate of unexpected newborn complications, and we need help on the ped side, right? So that kind of cross comparison is really important. I've already talked about this a little bit, but if you were to just look at that rate of Medicaid in the state, you're really looking at 50% or fewer deliveries being paid for by Medicaid. And we know it fluctuates, right? Depending how long it takes for the data to clear. But with adjudication, retroactive eligibility, with long-term stays for some of our highest acuity mothers, it really ends up being closer to 60%. And this is important because Medicaid is a driver of a lot of maternal health care and infant health care that's happening, a lot of initiatives that are happening in the state, not only AIM, but now TEMA. And of course, many of you are part of the, other work with quality and some of the hospital-driven initiatives. And so knowing that Medicaid is such a prominent force at your hospital and who Medicaid serves can really help with that policy lens and that policy shift. Okay. And then I won't go too much into this, but in this case here, we're looking at self-identified race versus billing race. And over here on the right, I believe this is an example of Hispanic ethnicity. Yeah, it's Hispanic ethnicity as put just from the billing record versus when identified by the patient themselves. And you can see there's about a 2% difference. So it does make a difference. And if you're really looking at data from that characteristic perspective and thinking about how you're going to reduce disparities, it's an important factor. So I don't know how I'm doing on time, Rachel, but I'm about to jump into an interactive dashboard walkthrough if that works.
So what I would like to do is pause for questions and discussion, and then we can move into how the dashboard can be used. So I'm going to stop recording.
That sounds great.
Okay, 1 second.
Would you like me to do a stop share?
Yeah, 1 second.